Everyone. This is the Finance and Planning Committee meeting of the Health Commission, and welcome again, everyone. Mark, would you mind doing the roll call and the acknowledgement?
Sure. I'll start with you, Commissioner Chung,
Present.
Commissioner Guillermo, and Commissioner Chow.
Present.
All right. I will read the land acknowledgement. The San Francisco Health Commission acknowledges that we are on the unceded ancestral homeland of the Ramaytush Ohlone, who are the original inhabitants of the San Francisco Peninsula. As the indigenous stewards of this land and in accordance with their traditions, the Ramaytush Ohlone have never ceded, lost, nor forgotten their responsibilities as the caretakers of this place, as well as for all peoples who reside in their traditional territory. As guests, we recognize that we benefit from living and working on their traditional homeland. We wish to pay our respects by acknowledging the ancestors, elders, and relatives of the Ramaytush Ohlone community and by affirming their sovereign rights as First Peoples. The second item on the agenda is the approval of the July 2nd, 2024 committee meeting minutes.
Okay. Do we have a motion to approve?
So moved.
Second.
And there is a person who received permission to provide remote public comment. So I want to make sure that he does not want to do that at this time. This is the time for public comment. Please raise your hand. Mr. Minetshaw, if this is what you'd like to do. I see no hands. So because we have somebody participating remotely, I have to do a roll call vote for each of you. So Commissioner Chung, how do you vote on this item?
Yes.
Commissioner Guillermo?
Yes.
And Commissioner Chow?
Yes.
All right, thank you so much. The minutes are approved. We can move on to item 3, the monthly contracts report.
Afternoon, Commissioners. Michelle Ruggles, Department of Public Health Business Office. And I am going to go through the monthly contracts report and then turn it over to other DPH staff to present the standalone contracts. So the first contract that I have today is Richmond Area Multi-Services, which I'll probably refer to as RAMS. And it is for their PAYS contract, which, let's see, I just lost, Personal Assisted Employment Services Counseling Program. This is a new agreement, but for continuing services. And so what we're asking for today is for a new contract that, let's see, to continue the services, which have been ongoing for years. And what this is a 1-year or 2-year, actually, up to 2-year bridge contract. This needs to be put out to bid. And so the solicitation hasn't been put out to bid yet. So this will allow enough time to have it developed, put out to bid, and then awarded. So what we're bringing today is a 2-year contract. The only change is that there's been a cost of doing business added to the annual amount. Do you have any questions?
I wasn't sure if I should wait until after all of the 3 RAMS contracts have been presented because I have a general comment.
Okay, if it's a general comment, we'll wait
Okay.
until we finish the other 2.
Okay. The next contract is Richmond Area Multi-Services RAMS, and ICM stands for Intensive Case Management / Full Service Partnership. So the purpose, again, of this contract, this is a new agreement for continuing services. These services were under an existing contract, and then they were the successful bidders when this was rebid. So the last time you approved this actually it was November 2022. So again, the change here is the reduction of one-time funding. The change here is just to show you, even though it's a new contract for funding levels between fiscal years, the last year, 23-24, had $200,000 in one-time training, which was one time, so it didn't continue. So it's fairly straightforward, but if you have questions, please let me know.
Any questions, Dr. Chow?
No, thank you. No.
Okay. All right.
Okay. The next RAMS contract, pay as transitional aged youth contract. So this also is a new agreement for continuing services. The requested action, well, we said it is a ongoing contract. The change here, I didn't say, I don't actually know what the change of $7,000 is. But that's the change. Anyway, that's the amount of funding in the new contract that increased the annual amount by $7,682. Again, these are ongoing services that were approved by the Health Commission recently on 11/1/22.
Any questions on this specific contract, commissioners?
No.
And I just wanted to add, Commissioner Chow had sent a question about the size of their portfolio and then wondering about their fiscal report. I think you might have received the fiscal report, but just in case, there was no findings in the fiscal report. And then I just wanted to add, as a point of reference, what they do in the citywide joint fiscal and compliance monitoring is they review accounting and budgeting standards. They have 12 standards in that category. They review 21 standards against the financial statements, and then they review 28 standards in the category of policy and operations, and then under governance, 19 standards. So that hopefully answers your question, Commissioner Chow.
Yes, you did, and I did see the report and had seen
Okay.
previously from other RAMS contracts. I'm sorry that I had missed the
Oh, that's okay.
report and the large amount of paperwork that we got. Thank you.
And Commissioner Guillermo?
Thank you. I have several questions and I appreciate all of the, as the Dr. Chow, all of the background information is very helpful. It just takes a while to get through everything. And that's why my questions are sort of for the total package. It seems as if the performance on these contracts ranks very, very high, which is great. And however, the units of service, I guess, quite different from what was quite different from what was contracted throughout. And I know that each of the programs have different contract years. And so it's sort of hard to, at least I guess for me, to kind of get a sense of how, to my question, how then will an approved budget be adjusted for the projected clients that were not and numbers that were not achieved? Does the budget get adjusted or over the life of a contract, or is there some other mechanism, or is each program different depending on what was proposed versus the actual?
Each program is different. For direct treatment service, well, to answer your question, if there's a change and they'll look at it and determine something needs to be changed, like it's too high, the unit of service, or too low, then it'll be adjusted in the next year. So, well, that's the goal. And then we've had the cost report, which will help. So there's an annual review. Still in New York time, and I cannot think. There's an annual process where they discuss the contract before issuing funding notification letters to kick off the new year. And so performance is one of the items that's looked at, like how are they doing? But I can say there's two things. One, for example, I took one of these contracts to the Board of Supervisors, and during that, looking at the units of service, realized that the way that they were reporting, they actually were under-reporting. And so in digging, figured out what was missing from the reporting. This was an employment program, but the supported employment staff weren't being counted, like that were hired to do janitorial. So as a result of that and looking at that, then we adjusted it into the next year budget to be more representative of what they were actually doing. One thing that you'll see, I noticed, I was gone when all of the documents were submitted, and I noticed in your packet there was an explanation of the LOE, level of effort, and CalAIM. I'm not sure what context that was included under, and I just noticed it 10 minutes ago. But one of the things that we'll bring more formally, because I think it will start to show up a lot more once it's all incorporated into the contracts, is that the way that units have traditionally been in a contract, and I'm talking about direct treatment where you enter your units into Epic now or Avatar, you take the total contract and you would estimate the units, and that would give you a unit rate. And so those unit rates were by the minute. So it was kind of maybe hard to, like, I don't know, what does 10,000 units really mean? But what's happening now under CalAIM is that they're looking at clinician type, doctor, therapist, whatever the different types are. And the units are based on the quantity of time that clinician billed. And so we have it's implementing now, and it will get into the contract. So once we're actually finalizing what it will look like, you'll start to see a change in the units of service, which is a really long answer to say there will be changes, and we do adjust it based on, if it seems like it's the right amount and they're under billing, is it because they're not documenting right, then correct, or documenting enough, then that might be the intervention. It's not just automatically reducing the units.
So it would appear, though, that because of COVID, there were significant variation in the contracted number of units, depending on the program and the actuals that were achieved. And so sort of another question related to that is, because the reports seem to be over a year past the actual end of the contract, how do those things then get adjusted? Or are we going to be looking at, just because it was affected by COVID, there's some mitigation, I guess, that is allowable? I'm just sort of thinking forward, because as we're approving contracts now for the future, and if the reports are going to continue to be in arrears like that, it's really difficult to sort of determine whether that is a aberration because of COVID or something we should be looking more closely at in the future.
Yeah, this one is, RAMS has tons of contracts and tons of programs, but what we could do is, normally this is this little like bad period in time where it's not even 22, 23. There's a lot of them that are done and some that are finishing. It's always a year after the fact, but we can definitely, we have the data. And actually, when we go to the Board of Supervisors, if the monitoring report's old and the units were down, we can get the current units to just have a comparison and then share that with you to give you more knowledge about what's more like current on the street. We do these always just so we have a historical record of a point in time. But yes, I agree, it is behind the time. But this is later than it should be, but it's always a year after at a minimum.
At a minimum?
Yeah.
Okay. All right. That answers most of my questions, but I just think it's something, particularly when we've got a large contractor that's got multiple programs over many years. I think being able to monitor real time would be an advantage. I mean, at least see the reports or the data more real time would be advantageous. So if there's a way that we could do that without creating more work unnecessarily, then I think that would be helpful for the committee.
Yeah. We'll think about what would be the best mechanism to do that. But we always have invoices. It's also, it's the pandemic, and now it's the transition to Epic. And so who knows what impact that will have on the units.
Well, sort of related to that is because, and I hate to carry this out, but from another perspective, if in the future, without COVID or without a pandemic or some crises, if it appears that an estimation of the contracted units is something that needs to be adjusted because, particularly in behavioral health, if it really takes more time to actually provide the service or, the training or whatever it is, then it would be, to me, more, I think, more important to assess whether we should lower the number of expected contracted units or service for a better quality outcome. Right. So that's one of the other things that, would be considered. It's not so much that you're not reaching your numbers. It's what really does it take to get, the outcome that is expected.
Yeah.
Thanks.
Thank you. That's great feedback, Commissioner.
Yeah, yeah,
Commissioner Chow?
yes, thank you. And I want to thank Commissioner Guillermo for her comments. I thought it would be worthwhile noting that I think the commission policy in the past has been approximately on contracts. We can give up to 10 years, but we'd like to see an overall review at about the 5-year level. So we've asked that contracts not be extended beyond 5 years, and we would. And I see there are these two contracts, which I think are really a good illustration that, in this case, gives us that, except for the units of service question, which seems to be affected by COVID, that the commission's able to see that these past 5 years, certainly in the report that we got from the previous year, and the track record they have, and the fiscal responsibility that RAMS has demonstrated, that this is a strong, this is a important deliverer of service of ours, and it has a strong financial record with us. And I just think that this was a good way that we're getting to see a 5-year picture of where we are with these large contracts. So I just want to commend staff for being able to give us that information. Also taking a little bit of pride that so many years ago, RAMS almost died, and this department really helped save it. And I think that nearly a number of decades having gone by, the city is really benefited from the fact that RAMS is continue to be a strong deliverer of services. I think the comment from Michelle about the level of effort, I thank you for clarifying that. I didn't see where this actually was affecting any of our current contracts, and I think we should look towards how you are really adjusting and letting us know then, rather than by the minutes or by the hours, what this is going to look like as we look at the different levels of personnel that are delivering service. So thank you also.
If I can jump in really quickly, Commissioners, I review all the materials before you get them and then give comments to the staff. And while you were gone, there was on the draft contracts report, there was a level of effort, units of service, and I asked what that is because I had no idea. And then they changed the unit and then gave us the definition, so it doesn't match anymore. But that it was, I guess, for the future, that's what you'll see.
Okay, thank you.
So, well, good. At least now we're prepared when this term comes up. Next contract, please.
Okay. Okay, this is a UC Regent contract providing services to Laguna Honda. The requested action is, this is a new original agreement for continuing services. And let's see, sorry, it's on 2 pages. There's an annual increase shown here for $238,643, which is an adjustment to the rate. This will be a 12-month contract. Oh no, 2-year contract. I'm sorry, I got in the wrong line. It's just 1 year.
It's 1 year.
Yeah, sorry.
It's 1
This
year.
is a 1-year contract. We have a new ordinance that passed, which is actually going to be super helpful to the department. It passed citywide. and in short, we call it government to government ordinance, which will allow us to enter into agreements with government contracts without having to do all the extra waivers and forms and solicitations that we might otherwise have to do for other contracts. And it just changes a lot of the requirements across the city departments when you're actually contracting with government. So we have a interim template that this is what this contract is. There's always a longer process when we're working out the boilerplate contract requirements between the department and UC. And so it's 1 year and then it will be reissued using the updated contract template. This is an ongoing service, though, that you last approved in August 2021.
Yes, Commissioner Guillermo.
Thanks, Michelle. Could you explain a little bit more about that change in boilerplate? Was it just for UCSF type of contracts, or is it for any? And just an example of what makes it so much better.
For UC, who has contracts across, right, the state, well, they're across the state, right? And so they can't be subject to the different policies that are unique to each county across that's underlying them. So as a result, with UC alone, there's up to 5 waivers that we have to process, and they're 100% of the time approved. So because they can't comply, they're not gonna, they maybe already do comply, but they're not gonna like do different things in every county. So I think the waiver.
No, that's, yeah,
So that's just one example.
that makes a lot of sense. Thanks.
Like if we pass money through, like we get Ryan White funding and pass it through to another, like to Marin, we have to get a waiver to get from Duke to do a sole source, which is sort of silly because, right? Like we wouldn't, there would be no purpose of bidding out that contract because of course they're going to get the pass through because that's the federal government gave it to us to distribute. So things like the takeaway requirements, just and boilerplate language that isn't applicable. So it'll save a lot of time actually. Okay, the next contract called A&A Health Services. This is a new agreement, again, for continuing services. This contract is essentially the same, and you did approve this. Did you approve this? Can't find it. But this contract is 1 year, and this also is another ordinance that was passed, which is going to be a big time saving for the Department of Public Health, which is an ordinance.
I actually think this is a 2-year contract, but
Oh, 2 year?
Yeah.
Okay, 2-year contract. Yes, 2 years. This contract, we piloted and then had a sole source, and now we have a bed ordinance, which is the shorthand term for this board amendment to the admin code that was specific to the Department of Public Health, but it allows us to enter into agreements for beds and associated treatment services without needing to do a solicitation. We could do a solicitation, but if what we need is an immediate bed and somebody has a bed, then this ordinance that the Board of Supervisors passed allows us to enter into those agreements without the whole elongated process. And so that is what this is. And this is a continuing contract for beds.
any questions, Commissioner? Oh,
With
Yes.
the pleasure of the chair, Rick Graham, Colfax Director. I just want to highlight how significant this change was. It went to the board, and this allows us to be much more flexible, more responsive to the needs for beds. Because as you know, there's a shortage of certain beds across the state. And what would happen was other jurisdictions would basically whip out the contract and get the beds before we had any hope of getting them. So this makes us a much more flexible system to basically buy the beds we need faster. It was there's a lot of bureaucracy that was broken down successfully by the behavioral health and contracts team to get the board to do this. So it's a significant step, even though now it seems simple. It was actually really, it took a lot of work to get it done. So just to highlight that.
Thank you.
I'll just add on that. You'll get an annual report. It just started, and I haven't brought you the annual sole source report. So you'll get a report each year that tells you when we've used this this bed ordinance to enter into an agreement.
Sorry, is this similar to what was done in order to be able to grab SNF beds outside of the county? This was, I think, a couple of months ago. Yeah. Okay.
Okay. The last contract is Siemens Industry, and this is an amendment to an existing contract to extend the term by 1 year and to increase the total amount by $552,000. You can see there's not really any change. This is the automation system at Zuckerberg, which controls the heating, ventilation, air conditioning, et cetera. And so this is continuing these services through an amendment.
Any questions, commissioners?
It's kind of like a very minor questions. What's the annual differences? Where did that $610 come from?
This was added while I was on vacation, but I might not have asked that question. I'm not sure. Rounding error? I don't know. I can get that for you though.
Okay, so yeah, it's kind of peculiar. Like what does that actually
Okay.
represent? But yeah. But yeah, no big.
I'm wondering, could I ask, I just realized, if it's a 1 year extension, why are we doing it for only 1 year?
Let me see if the representative.
Okay, Michelle, I think you helped.
Hi, I'm AJ. I'm Facilities Director over at Zuckerberg. The reason we had to do the 1 year extension is we're currently working on the 5 year, but we ran into some issues with the vendor getting the right info over to our cybersecurity team.
I see.
Okay, so it looks like that got cleared up. We hope to have the actual contract for the next 5 year by October, and then we have an option to opt out of this extension.
Okay.
Okay, thank you.
Yep. I don't know. I saw that. Sorry.
All right, so commissioners, there is a public comment. So unless you have other questions, if you make motions, then we'll go to public comment, then we'll go to your vote.
I so move to recommend the contract report to the commission.
Second.
All right, and we'll go to the member of the public. Mr. Mitchell, would you like to make comment on the contracts report?
Is this the time to talk on item 4?
No, we're on item 3.
Okay, I'll wait.
Okay, great. Thank you. So commissioners, I will do a roll call vote. I'll start with you, Commissioner Chow,
Yes,
Commissioner Guillermo,
Yes.
and Commissioner Chung.
Yes.
All right, thank you very much, Ms. Ruggles, and everybody who helps with that. Item 4 is a request for approval of a new professional services agreement with Health Services Advisory Group.
Good afternoon, Commissioners. Roland Pickens, Director of the San Francisco Health Network. I'm here to request your approval of a new professional services agreement with Health Services Advisory Group for technical assistance in performance improvement and evaluation services to sustain compliance with state and federal regulations at Laguna Honda Hospital. Health Services Advisory Group, under this contract, will perform services to support, at a minimum, Laguna Honda Hospital's sustaining compliance with state and federal regulations, as was acknowledged with the recent recertification by CMS. This is specifically for skilled nursing facility expertise. Health Services Advisory Group will, at a minimum, provide 4 on-site visits annually, which may include pre-visit preparation, entrance sessions, and exit sessions, as well as exit reports. In addition, Health Services Advisory Group will provide technical assistance and project management services on an as-needed basis by the professionals listed in the contract if circumstances may require. And I think it's important to note that how this relates to the contract that the Commission recently approved for HMA, Health Management Associates. And the response is simple. Health Services Advisory Group is a niche consulting group that focuses and specializes only in skilled nursing level of care. And whereas the HMA contract, HMA is a general healthcare consultant that specializes not only in operations, but in policy, finance across multiple sectors, including acute care, long-term care, rehab, and behavioral health services. We're requesting approval of this item at this time and would be happy to take questions at the appropriate time.
And Commissioners, there is someone, a member would like to make comment, so we'll go to that first. Commissioner Chung, is that okay?
Yes.
Okay. Mr. Minichal, I'm going to pull up your slide and then I'll pull you in. Actually, no, I need to unmute you first. Give me 1 second. Okay, don't speak yet, Mr. Minichal, so the image comes up.
All right.
Okay, you may begin. You've got 3 minutes.
Thank you.
This is Patrick Monette Shaw, code AA. Instead of issuing this new $10 million contract to HSAG, which is astronomical, LHH should just hire experienced staff who know what they're frickin' doing in running a skilled nursing facility. Does this commission really believe that LHH's management and staff will need to be monitored by an external consultant for fully another 5 years into 2029 to prevent LHH from being decertified again? As my chart on the overhead display shows today, since my Westside Observer article was published May 26, 2024, in which I documented that overall costs to rescue LHH had reached $177.5 million, costs have climbed by another $14 million to at least $191.5 million and are still climbing. Across the past month alone, LHH has awarded 2 contracts totaling another $13.2 million in consultant contracts to HMA and HSAG. My chart today shows that costs for external consultants since May 1st, 2022, just after LHH was decertified in April 2022, and through the next 5 years to 2029, have now reached $53.6 million. The Health Commission is apparently okay with throwing $53.6 million in consultant costs to fix LHH's decades-old mismanagement problems to see if external oversight might help, rather than hiring competent LHH staff. It's disgusting, at least to me, that Melgar, Reed, Heskin, and the full board of supervisors are going along with this scam. Part of the criticism of the Health Commission's failure as LHH's governing body is that this commission is not performing sufficient fiduciary restraint to rein in the needless $53 million in consulting contract expenses. As fiduciaries, this commission is bordering on fiduciary neglect and fiduciary malfeasance. These costs could have been avoided all along had LHH just hired folks who knew what they were doing before LHH was decertified. Of interest, the new $9.999 million HSAG contract is just $1 shy of triggering that the contract must receive full Board of Supervisors approval for contracts exceeding $10 million during a Board of Supervisors open public hearing. Thank you.
All right, give me a second to take this out. All right, commissioners, that's the only public comment on this item.
Commissioner Guillermo.
So with the HMA and the HSAG contracts, if you could just clarify, these are, we'll be drawing down on the services as needed, right? So
Correct.
the total amount of the contracts is as if we were going to be able to, or needed the total amount of services I would provide, and they would use up the whole contract, but otherwise we're not.
Correct. This is a cost not to exceed, not that we are anticipating exhausting all of it, but we wanted to make sure we have the runway in the contract. Again, depending upon the volatile nature of this road to regulatory compliance, not wanting to be able to anticipate even future unknown needs as they may come up. But by no means does a total amount represent what we may actually spend.
And could you just let us know which of the contractors has the most experience, or in your opinion, the most expertise with phase 3 regulations?
Health Services Advisor Group by far. Skilled nursing is all they do. They don't do acute care, which is why we need the HMA contract because of the vitally important 11-bed acute care unit at Laguna, which really drives our financial performance and has its own whole other set of requirements.
Thank you.
Commissioner Chow has his hand raised.
Oh, Commissioner Chow.
Yes, thank you, Mr. Pickens, for your discussion. And of the amount of money, then the only thing that actually is a deliverable is the 4 site reports, right? And is that is that an annual report that we're looking at, or that's per year?
Thank you for the question. So correct, it is only at a minimum those 4 quarterly reports. So those will be 4 per year, starting with 4 for this year. And again, our plan is to see, do we, on the long-term basis, need to do 4 a year, or are things really looking better and we can cut back to maybe 3 or 2 a year? But the start is 4, and then we'll reassess as we go into the outer years.
Okay, so that means it's about 1.5 million per year, the way that you've scheduled this out, and that can be scaled back as needed.
Correct.
Right, and therefore then the remainder of the listings of the types of management services is also as needed, right? So I think that helps clarify what types of services we're expecting, and I appreciate also the distinction between HSAG and HMA. So thank you very much. And considering that our enterprise is over 200 million per year, I think at least at the Laguna, then spending about 1.4 million to make sure that everything is in place, especially in the first year, answers some of our questions in terms of how we're going to sustain ourselves, right? I see that the dashboard is now been discontinued after a successful recertification. So this sounds like on a quarterly basis, we're going to be able to get reviews to make sure, at least in the first year, that we have not slipped backwards. So I appreciate the contract. Thank you.
Yes, Commissioner Kovacs, Director Kovacs.
I just wanted to ask Mr. Pickens to clarify, the dashboard is changing to a sustainability dashboard, just to make sure everybody's clear, and Mr. Pickens will make it clear for everybody. We are still holding ourselves accountable to key metrics to make sure that the quality of Laguna Honda continues.
That's right. So both Dr. Colfax and Dr. Shaw are correct. So what was titled the Laguna Honda Key Performance Indicator Dashboard was the last report was released this week. That will be discontinued, and in its place will be a new performance improvement reporting dashboard for sustainability and stabilization. So in addition to having that report and the quarterly reports, that's how we intend to keep everyone informed of the progress and level of care at Laguna, both the JCC, the Health Commission, and most importantly, our staff who are actually delivering the care.
Any other questions? So personally, I actually appreciate this kind of like independent monitoring and evaluation process. And I think that in the long run, if it's done well, it would actually improve, the quality of services, of the hospital overall. So I think, right now the pressure is like how this will transpire after the first year and what would the reports tell us. So we look forward to hearing about those reports, after the first year to see how things are going, which direction it's going.
Absolutely.
Thank you.
And so please, commissioners, please consider a motion to approve or recommend to the full commission to approve this contract.
I'll move approval.
I would second that, please.
All right, I'll do a roll call vote. Commissioner Chow,
Yes.
Commissioner Guillermo,
Yes.
and Commissioner Chung.
Yes.
All right, thank you so much. We can move on to item 5, a request for a retroactive approval of a new professional services agreement with the Regents of University of California for the citywide case management program.
Good afternoon, Commissioners. I'm Angelica Almeida, the Director of the Adult and Older Adult System of Care with Behavioral Health Services. And I want to recognize and appreciate that I'm joined by 2 members of the UCSF Citywide team, the Interim Division Director, Dr. Cunningham, and the Deputy Division Director, Allison Livingston, if there's any programmatic questions. As noted, we are seeking retroactive approval of a new contract with UCSF Citywide. The total proposed amount is $6 million and would cover 3 years, 8 months of services retroactive to November 1st of 2023. This was an RFP that was awarded to UCSF to provide intensive case management services to adults and older adults in our system. As is true of all of Citywide's contracts with us, Citywide is particularly skilled in working with individuals who have complex needs and certainly individuals with complex cases with diverse backgrounds, including those who are experiencing homelessness or exiting the criminal justice system. This contract will serve 45 individuals annually and includes a funding mix of both Medi-Cal, MHSA, general fund dollars, and realignment funding. I'm of course happy to answer any questions that you may have.
Thank you. Commissioner?
I think there was a question that Dr. Chow had asked about the cost per client per year. So it said that the question was going to be answered during the presentation.
And I think, Dr. Chow, please correct me if I'm wrong. I think that might have been related to the Care Court contract, which.
Sorry,
is
yeah,
our next-
you're right. Yeah.
Okay, just wanted to confirm.
Yes.
Any other comments, or do we have public comments on this item?
No public comment for this item.
Okay, can we have a motion to approve this?
I would move recommendation of approval to the commission.
Second?
Commissioner Chung, how do you vote on this issue?
Yes.
Commissioner Guillermo
Yes.
and Commissioner Chow.
Yes.
All right, thank you so much. The item will be moved to the consent calendar on the full commission meeting agenda today. We can move on to item 6, a request for a retroactive approval of a new professional services agreement with UCSF, Citywide Community Assistance Recovery and Empowerment or CARE team.
Okay. I am still Angelica Almeida, Director of the Adult and Older Adult System of Care for Behavioral Health, and they have not left yet. Continue to be joined by Dr. Cunningham and Ms. Livingston from UCSF Citywide. This is also a new contract. This is a sole source contract to provide clinical services for individuals who are court-ordered or enter into a care agreement, for those who are involved in the Community Assistance Recovery and Empowerment or CARE Act. This is a civil court process that we implemented as a Jurisdiction 1 starting October 1st of 2023. This is very similar to our assisted outpatient treatment program, in which we have a civil service team that is designated to outreach and engage individuals, identify those who are appropriate to go through this process, make recommendations to the court, and liaison with the court. And similarly, we partner with UCSF also for assisted outpatient treatment to provide intensive case management services to those who have gone through the court process. And I know, Dr. Chow, you had a question around this. This includes, this will serve 30 individuals, and the treatment providers include LPCCs, MFTs, or social workers, as well as psychiatrists and other team members who will provide those services. Citywide is, again, particularly skilled at providing extensive outreach to individuals and engagement. And as is true of our other court programs that we partner with UCSF with, Citywide will partner closely with our DPH team as well as the court to outreach and support that relationship building to engage people in care. While we'll have a court order to engage these individuals and to support them to participate in treatment, our goal, of course, is always to get to a point of voluntary services. So this is approximately for $5.2 million, and we are requesting retroactive approval from May 2024, and this would go through June 30th, 2026, which would allow us to go through an RFP process during that time so that we can continue to serve people. This is currently funded through state funds, and then future years will be funded through general fund to continue to support this process. And of course, happy to answer any additional questions, although Dr. Chow, I realize I didn't answer your question. So my understanding from our director of Care Court and looking at the discrepancy in terms of the rate of units of service is that had to do with rounding, I shouldn't say error, but rounding on the Excel document. So that's why it looked a little bit different. But we certainly check that and we'll continue to partner very closely with Citywide around serving these individuals.
Any other questions? Commissioner Guillermo?
So the number of units indicated here for 30 clients is 3,763. Is that hours? Is that just the arithmetic, Michelle, that you sort of alluded to in terms of how you get to units of service, and that's going to change?
Units of service isn't necessarily hours. We'll leverage Mode 15 billing with Medi-Cal as much as we can for this. So it depends on the type of service that's being provided, how many units are offered. As Ms. Ruggles was discussing earlier, through CalAIM, this is really the vision of CalAIM to look at are people getting better and less around units of service. And so it is shifting to a model of level of effort. And as was described, depending on the practitioner type, psychiatrist, nurse practitioner, nurse, clinician, social worker, for example, or a peer, there's different levels of efforts outlined by DHCS. On average, it's around 40% that's required to be direct service. So rather than looking at particular units of service, it's looking at are 40% of a person's time providing direct care to a patient, and are those patients getting better?
So in the future, when it comes back to us and is requesting general fund, then this number of units will be now showing as level of effort? Or something else?
It's definitely complicated, and I think we're in a transitional time right now. So I think those are still details that we're figuring out and trying to navigate that. But of course, I'll defer to Ms. Ruggles around that.
Yeah, so it's being figured out, but essentially the state assigns a level of effort of how much direct treatment time
Right.
is expected for each clinician type. And so that's a formula. You can take the FTE hours, full-time and calculate it. So that will be the aspire to number, I guess.
So is it going to be like a score or how does that work?
It'll be so if I'm a clinician and I'm expected to spend 40% of my time, and I don't know the math, but let's say it's 1,000 units of services. So that number will be all the numbers of the clinicians will be added up. It's more complicated right now because it's new and they're developing the reports. And we're also, the productivity standard is different, if you will, than what's actually being delivered. So we're trying to match and see what, is this realistic? I mean, the state told us, but is it? Trying to look at that. And then we also, in this transition, don't want any vendors to lose money because we want them to stay whole, providing the same level of services. And so there's a blended rate that is going to come out of this. And so I think that's what you're going to see, not the level of effort, but that's what it will translate to. But I promise you, we'll have a whole cheat sheet because we are actually actively trying to figure that out to explain to the our contractors, because we need them to tell us, instead of like, here's all my staff, we need them to say, this staff is this kind of practitioner, this staff is this kind. Then internally, DPH will do the formula to figure out the number of hours, which will be provided and then put back into the contract. So there's a lot going on, but promise we'll bring the cheat sheet and what the translation is, because it's not one for one.
So what I'm hearing here, correct me if I'm wrong, because the rate would look different for the actual client time versus the administration time.
It'll be a blended rate. And so the units of service are going to be reflecting the direct treatment hours. And then you'll take the total cost, dividing it by those treatment hours. That will be the blended rate. And so we'll have to redefine what the unit of service is, because it's only going to be the direct treatment. So if you're doing things that aren't like actually billable, that's not going to show up in the units of service. This is for outpatient programs and residential treatment.
So you'll redistribute the administrative overhead costs across the units of service. So then you'll get the blended rate, right? Yeah, whatever that, yeah.
And that's something the state is currently looking at. So that'll get rolled up. A good example is particularly for intensive case management services. As I was talking about, like this program will require a lot of outreach. The state doesn't allow us to bill for like time that we're outreaching somebody unless we're directly with the patient. That being said, like what they're looking at is, as we're gathering all this information, is that gets all rolled up into one rate. So the idea is that these are all services that we're providing to people, and there's one blended rate, as was noted.
So it's like a cost accounting kind of approach to.
Blended rate. So I guess if we were in a perfect world and there was just one jump and transition and no worry in the world, we would just have, here's your clinician, here's your units, here's your clinician, here's your units, here's the rate that's what the state will reimburse us. You billed for 15 minutes, there you go. And then that would cover everything. But we're not there yet. And so instead of just doing clinician and having an invoice, if you will, that was all the hours, we're taking the estimated all the hours, but but still including the total cost that the program's currently been paid. So the blended rate is interim. Maybe it won't be interim, but that's to.
It's kind of like all those like restaurant delivery, the actual
Add-on fees?
Yeah, add-on fees, like the administrative fees or whatnot to support, the overhead.
But justified. I wish you a lot of luck. And really, because I know it's complicated and you may not get it right the first time, right? So we'll be anxious to hear how it goes because after this, it's going to be general fund money. And so we're going to have to really, I mean, not that we don't care about state money, but general fund money, we have to be much more careful about in terms of making sure that we're
Yeah, and we're
budgeting
really
correctly.
excited to
Yeah.
like look forward to like hear about the first year outcome because that's what it matters. It's like what improvement it actually provides for the quality of life of these clients. So
Exactly.
appreciate that. So do we have a motion?
I'll move approval.
I'll second this.
Commissioner Chow, how do you vote?
Yes.
Commissioner Guillermo
Yes.
and Commissioner Chong?
Yes.
All right, thank you very much.
Thank you.
We can move on, let's see, to item 7, request for approval of a new professional services contract with Public Health Foundation Enterprises.
Good afternoon, Health Commissioners. I'm Albert Yu, the Acting Director for Ambulatory Care. I am here to seek a sole source waiver for a contract directly with Public Health Foundation, Enterprise Foundation, aka Luna Health, for the Abundant Birth 2.0 project. The reason why we're doing a waiver is they did 1.0, or Abundant Birth Project 1.0. This program is a total 2-year funding contract at $1.5 million total, with the goal of enrolling 70 moms with a monthly payment of $1,186 for a total of 12 months duration. That's pretty much the contract. There was a question from my health commissioners around the non-guaranteed income portion of that 1.5 million, which translates to about 480,000 or so over 2 years period. That is to cover one, a 13% indirect expense cost, which the county set as a cap rate. Second, there are 2 FTE staff that will be part of the program. They do a number of services that was sort of in one of the commissioner's questions. Obviously, they have to review all the applications to determine eligibility qualifications. And there are very specific sort of who qualifies for that particular guaranteed income payment. 2, they also have to do an intake and orientation to the entire process, as well as the ongoing services that each mom would receive. 3, they will also have what's called benefit kind of counseling. The benefit counseling is to really assess whether a mom qualifies for other statewide agency benefits like CalWORK or other eligible subsidies that a mom who, based on economics or based on other parameters, so that we can actually help that mom enroll, not we, but the contracted staff would help the mom enroll into all of those state agency programs. Next other service they do is also resource sort of linkage and connections, in addition to just giving the guaranteed income, whether it's to primary care or to support services or to housing services and et cetera. There's also abundance coaching, because this is a part of prenatal care, which has a lot of coaching benefits in terms of both how to take care of oneself during the prenatal period as well as postpartum. So there's a bit of sort of abundance coaching support there for the prenatal mom. And there's a little bit of community outreach, mostly from a promotion and outreach to generate enrollment, or I shouldn't say enrollment, application into the program. And then they get enrolled if they qualify. A tiny bit on sort of social marketing and outreach. There's also an evaluation component, which is separate from the program itself. The evaluation component has a separate IRB research protocol from which the enrolled moms, I don't believe the family, but just the enrolled moms, will also go through a number of sort of mental health assessment to better understand how effective this overall program is. That evaluation is not part of this funding. There is no money in this program that goes to the evaluation because that's a separate sort of IRB research protocol. I'll pause here and see if there are additional questions from the 3 commissioners.
So 2 questions. One, how did you reach the number 70 or the 35 per year? Sort of what calculation goes into that? And then 2, what are you said there's 2 FTE. what kind of positions are those that are providing all of those benefits?
First question. A question. We went back and forth on what the Public Health Enterprise Foundation were proposing in terms of number of moms that they would be eligible. We essentially just used the math, 1186 times 12. That would be each mom, right? Because they're getting 1,186 per month for 12 months. And then we said, okay, if we had 60, 65, 70, how much does that add up to? That added up to a little more than $1 million. And then we factor in the 13% indirect costs into that 1.5 million budget. And then we factor in the 2 proposed FTE based on their 1.0 FTE compensation rate. And then just a tiny bit, I think, on expense. There's a third-party vendor that they contract with which provide a technology solution. That's a kit that essentially allow the moms to apply, to allow the moms to sign in, to get the payment, and et cetera. So essentially, we just factor out indirect costs, the 2 FTEs, and the A-Kit technology solution, and then say, okay, what's left from the 1.5? Divide that by 1186 times 12. Simple math.
Okay.
Then
No, that makes,
no magic.
yeah, okay.
Nothing magic.
That'd just be interesting to see then if those numbers are, if we're able to reach those numbers, or if it ends up being so effective that we want to grow the program, or, you know, some other sort of adjustments. So then maybe the budget can be based on something other than the math, and can be based on the process and the outcomes. Okay.
And now I forgot your second question. Apologies. You had 2 questions.
Oh, the staffing, what level of staffing is that?
I'm not I mean, it's a good question. I'm not sure what level of staffing they proposed, but there were 2 staff, and one was like $69,000, one was $56,000 in terms of the compensation.
Just in time, because that's a lot that we're asking those staff to do. And so, you know, counseling, outreach, you know, all of those kinds of things. And so I was just curious.
Yeah, they didn't, I mean, their sort of initial submission on the budget did not specify sort of what the requirement of that job role is, but they did provide sort of salary compensation.
I think that would be important to be able to know, just because recruiting people into the program and providing those services is going to require some expertise. And so we'd want to be able to sort of, in terms of the outcomes that would be measured, you know, is that the right type of staffing?
Yeah.
Dr. Yu, can you check on that and just get back to me via email when you're able to find the information out?
Oh, of course. We're actually in active negotiation with the foundation on the actual contract itself, because we have to get all those documentations ready for the Board of Supervisor waiver presentation anyway. So we will definitely ask that and get details.
Great, thank you.
I had I had 2 questions. I'm curious because we've had several maternal programs. One of 2 specifically that I recall. One went up to UC, and one, I think, to a outside contractor that was looking particularly at the low income and the African American population. So if the key here and the key emphasis seemed to be the way it was written, that we were talking about giving money to a population, why couldn't all of these ancillary functions be done within using those existing programs, and then having them actually just hand the chart? This is like almost a 30% overhead in order to provide this grant to the 30 individuals.
Yeah, Dr. Chow, I appreciate the question, an important one from a financial, stewardship perspective. I'm not familiar enough with the 2 contract that you're referencing relative to UC in terms of what the scope of work is in those contracts. This contract is a sole source contract directly with the Public Health Enterprise Foundation. So there is no UCSF involvement in this contract.
But wouldn't some of this be the same population that we're all trying to reach? And
So it sounds like this
spending
is
30% extra, and that's not money getting to the needed recipients.
Well,
What was behind the idea of having a separate contract in order to give grants to worthy low-income people who were at high risk in pregnancy, and many of them were African American, and we heard of at least 2 programs already that was geared up to do this. And the second question I have is,
Evaluation component to this, right?
Actually, I also want to ask, is there a timeliness to, is there a, if this was delayed in any way, would this impact the program? Because these are some kind of fundamental questions that are happening, and it might be good to clear them up
Sure.
before. But how would that impact? Actually, since you're still negotiating, it seems like the timing might be okay to bring back in September.
So, couple of thoughts, Commissioner Chow. One is there was a AP Abundant Birth 1.0, which was initially a San Francisco-based pilot. Same thing, it was performed, that contract was given to Public Health Enterprise Foundation, Haluna Health for that contract. And that pilot, APP 1.0, was quite successful, which led to a statewide abundant birth program that involved 5 counties initially. That was the proposal.
Yeah.
San Francisco was one of the 5, but we decided to pull out of that statewide 5-county sort of larger sample, larger impact evaluation perspective. Because we pulled out, our mayor's office have committed $1.5 million in general funds to support APP 2.0. We had to do a waivers because Haluna Health is really the lead in driving APP 1.0 and now in 2.0 with other 4 counties. In fact, the other 4 counties have been live since July of 2023. We, in our county, did not have the APP 2.0 done yet, mostly because we did not initially follow the proper contracting, funding notification, contract negotiation process. So by the time we sort of realized why we were stuck with a contract, we are now at a point where we know exactly what needs to be done. We're trying to get it to the Board of Supervisors in the September cycle for the waiver, but there are still a couple of significant hurdles, and those are the city terms and conditions that needs to tie into our contractors as well as our contractors' subcontractors, because Haluna Health in this situation have a couple of subcontractors, both in the evaluation side as well as the technology platform, AKIT. So those contracts have all been signed by Haluna with these entities. With the other 4 counties, they've been live for a year. So in order for us to move all the available documents and be ready for the Board of Supervisors waiver meeting, Haluna would have to modify all the existing contracts with our terms and conditions as part of, because none of them are, well, I take that back. The universities are a government entity, but because we have a third-party non-government entity here, we can't use what Michelle Ruggles was saying earlier in terms of that government-to-government template. So it still will be longer. And all that said, that there's a risk that we won't be able to make the September Board of Supervisor cycle. And even after that, just a normal contracting process, right? After the board, the mayor has to approve it, and then we still have to take it in-house to finish the actual certification of that contracting work, even after the mayor has approved the waiver, okay? So it may be several months before we actually have the contract fully certified, before we can actually begin the enrollment, actually not enrollment, the application of moms, and then the selection of moms, and then enrollment, and then start paying.
Well, it seems you've given a better explanation than has been written up as to why the project is moving forward, and you gave us the fact that a pilot was successful, and we're now behind the 8 ball by about a year with other counties who had moved forward. And I guess that there is some urgency, since we don't seem to be moving very rapidly on the program. So I understand that if there was a pilot and this has worked, and we're not looking at duplicate populations to which we are putting a lot of resources into, especially the African American, low income and high risk, because this also is high risk. You know, I understand, you know, the bureaucracy that has caused these delays. So, you know, I won't comment on the validity of the program then. I do wonder why we did not get the Public Health Foundation's financial report that we are supposed to be receiving with these contracts. We have a lot of contracts with them, and the next one following would say that there are some deficits. I don't know if Laguna Health, Laguna Health, you know, has a strong financial page, and one of the things we're looking at is finance. So I asked that question earlier, and I don't believe, Mark, that they did submit to us, right? The report, even if they're asking.
Correct. But I'm not sure if that was a oversight. I don't know if that was intentional, but is Wasim? Oh,
It's an oversight.
okay, yeah, sure. I mean, again, because Ms. Ruggles was out, there was somebody else doing, I heard, an incredible amount of work. And so I think that was an oversight. But by the full commission meeting, maybe in the next hour, could we get that sent to us just so we have it?
Commissioner Chow, just one clarification to what you said. The criteria is not just Black, African American, and poverty. There are 5 risk factors that qualify a mom for enrollment and receiving of the guaranteed income. Black African American is 1, previous preterm birth, live before 37 weeks, pre-existing hypertension or preeclampsia in prior pregnancies, pre-existing diabetes before this pregnancy, as well as sickle cell anemia. So there are a couple of high-risk conditions that are also factored in there for preterm birth. Obviously, as you know, as a doctor, there are multiple factors for preterm birth, but these are the 5 that was used for
Sure,
this particular enrollment.
I'm not in disagreement. I'm just saying that we have cohorts who are already receiving a high amount of support, including some of the sports that you've talked about here. And we're spending a 30% overhead in order to give these people a certain amount of grants. I'll bet you that within those cohorts, they all meet those 5 criteria. And I'm just looking at this from a standpoint that we, you know, for every dollar, I mean, we're spending a 30% overhead in order to provide a grant. That's all.
Dr. Yu, there was an RFP. Ms. Brown is about to present a contract that is, I think, the final contract in RFP for maternal child health that focus on this population. This committee's seen 4 contracts come through that serves this population. Obviously, this is a different niche, but this is what Dr. Chow's referring to. And it doesn't make sense from just an outsider's perspective that there wouldn't have been more coordination. Obviously, at this point, it's late in the game to deal with that, but just noting Commissioner Chow, the context of Commissioner Chow's comments. So commissioners, how would you like to proceed?
Do we have a motion?
I'll move approval, given the, I think that the sort of time constraint, it would be a shame to not be able to make that September waiver meeting.
All right, I would second, providing that we get the financial summary.
Sure, yes. The staff of the room are nodding their head. So I'll do a roll call vote. Commissioner Chow,
Yes.
Commissioner Guillermo,
Yes.
and Commissioner Chung.
Yes.
All right, thank you. Let's see. Item 7 is request for a retroactive approval of a new professional service agreement with the Rafiki Coalition.
Hello, Commissioners. Again, hi. I'm Jessica Brown. I'm the Director of the Office of Justice, Equity, Diversity, and Inclusion, and also now known as the Behavioral Health Services Act. So I'm here today to present to you all on a request to retroactive approval of a new professional service agreement with the Rafiki Coalition for Health and Wellness to provide Black African American mental maternal health program. The total proposed agreement is in the amount of $11,369,952,000. and which includes a 12% contingency for the term of December 1st, 2023 through June 30th, 2028. The goal of this program is to serve Black African American communities in providing equitable, trauma-informed, and culturally responsive prevention and mental health care through the prevention outreach and promotion, as well as capacity building of training our mental health providers on pre and postpartum mental health concerns. This is also in coordination with other CB community-based organizations that we've worked with in the past, such as UCSF Embrace, and also RAMS and Homeless Children's Network, which will provide a community-based support group for clients that enter into their clinics. In addition to Rafiki will be increasing high-quality, culturally responsive mental health care for Black African American communities that harpen on the lack of access due to inequitable social determinants of health and the shortage of community and culturally aligned mental health care professionals, as well as reducing stigma in mental health in Black African American communities. Under an established Embrace model with the UCSF, Rafiki will engage families from pregnancy through the first year of life. So this will be postpartum, pre and postpartum, and offering prenatal services to support the health and mental health and wellness of the clients. They will also be working with UCSF's Embrace program in their prenatal outreach program as well to be able to refer clients. Clients will also be from the Bayview and also to Potrero Hill as well, as where we'll be having the clients for Rafiki. The reason why we're asking for this retroactive request is that as a new program was awarded from the solicitation, there were delays in developing and receiving contract documents, coordinating the approval of the city attorney. As a result, additional time was needed to gather information, prepare the term for the Health Commission. The contract was not fully certified until recently last month, July 24, 2024. Rafiki has been able to do a couple of the program startups, such as hiring staff and conducting community-based needs assessments by having town hall meetings, as well as pregnancy pop-up villages, to get an assessment of how the needs of this particular community as well. In addition, we anticipate that we would like to begin to start this program to be able to serve the clients and provide Rafiki with 6 months' time to continue to hire staff. They hired on a peer navigator as well as a therapist prior to this contract being certified. And then we also want to give them 9 months to actually implement the program based off of the time, the delays of the contract. In addition to, there was a question regarding their negative balance of $2,735,000, and this is due to the city and county's late certification of the grant. The organization could not recognize the grant revenue in time for the city fiscal monitoring. Therefore, the organization has a negative balance, and they have recently provided an updated profit and loss statement. Pause there for any questions.
Commissioner Guillermo?
So if you could just describe what the different roles are for the UCSF Embrace and the RAMS subcontractors to Rafiki?
Yes, so they will be providing a network of referrals as well. So RAMS will be serving clients and providing prevention and outreach efforts as well in coordination with Rafiki. UCSF Embrace program has been a long-term established program, so they'll be having providing the best practices for each of these two new startup programs to be able to implement. So it is an expansion of the UCS program to be able to provide a more larger net to other clients that were within the African American population throughout San Francisco.
And the contract doesn't specify the number of proposed clients.
Yes.
So how will that be measured then?
So given that, again, the delays, unfortunately, what we did was we took the average of what UCSF serves, which is 100 clients per year. With the prorated amount for Rafiki, they'll be serving 40 clients with the expectation that they will ramp up to 100 clients per year once they're fully implemented and fully staffed.
Can that be reflected in the contract now that you have the numbers?
Yes.
Before we go to the full commission?
Yes, we can. Yes.
Oh,
No, in the contract, in the memo.
Yes, we can.
Any other questions, commissioners?
Well, I think that it was appropriate to try to put the number of people that we're going to be doing. And I think this is a good example of the collaboration and using already existing networks and clients in order to provide an additional benefit that is support for their mental health programs. So I'm still a little concerned about Rafiki's financial because this contract itself would have been for the initial year 1.2 million, but they had a large additional gap, 2.7. So how did they close the other part of the gap? Were there other grants that they were losing? I mean, that they were not posting that were anticipated?
This is for the, oh, sorry. Oh, go ahead, sorry.
And please introduce yourself, Wasim.
Good afternoon. So actually, they did have
Oh, actually, please say who you are and what your title is.
Wasim Samar from the business office, the citywide fiscal and compliance monitoring. They did have other grants with, well, other contracts with the Department of Public Health. They have other grants with the Mayor's Office of Housing, MOHCD. But their response showed that the delays was in the Department of Public Health contracts. Some of the templates they received in May, so that's when they started billing us. And then they sent us an updated, income statement or profit and loss statements showing, after they recognize all the revenue, pretty much almost a break even, just a small deficit. So it was mostly Department of Public Health. There was, I think, two other contracts or three. Yeah, total 3 or 4 with Department of Public Health.
Okay, thank you. I appreciate that explanation.
Any other questions, commissioners? Consideration from,
did you move, Dr. Chow?
No, I'm
Second.
move the contract for approval by the full commission.
Okay, I'll second.
all right, Commissioner Chung, how do you vote on this item? Commissioner Guillermo
Yes.
and Commissioner Chow.
Yes,
Thank you, Ms. Brown.
You.
Item 8 is a request for approval of new equipment, software license, and maintenance contract with Securitas. I think that's how you say it, healthcare.
Good afternoon. I'm Tim Van Schoonhoven with Department of Public Health Information Technology. My team will be the team that's supporting this technology. The existing technology from Securitas is called Hugs LawnWorks, and it's end of life. So the driver for this contract is to replace it with a newer technology that's fully supported. The new technology, Hugs Wi-Fi, is based on our current AeroScout system that we use for patient tracking at Laguna Honda and Zuckerberg San Francisco General Hospitals. So our plan is to deploy this newer technology for infant tracking as well, and to support it in-house with our technicians alongside a maintenance contract with Securitas in case we need to escalate support. There was a question from Commissioner Chow regarding if we're satisfied with our current Securitas relationship, and from my experience, I would say yes. I'm not too familiar with the Hugs LawnWorks system because that's supported by facilities and a third-party vendor. But from the AeroScout side and what we expect with Hugs Wi-Fi, I don't anticipate any issues.
Was this under a competitive bid process?
It was not. It was a sole source. Any other questions?
I'll move approval for the full commission.
I would second.
Commissioner Chung, how do you vote? Commissioner Guillermo
Yes.
and Commissioner Chow.
Yes.
All right, thank you.
Okay.
We
thank
can
you, Joel.
move on to item 9, emerging issues. Hearing none, we can move on to public comment. Is there any public comment in the room? Not online. So we can, consideration for adjournment, please, commissioners.
I'll move to adjourn.
I would second.
Commissioner Chung, how do you vote on this issue? Commissioner Guillermo
Yes.
and Commissioner Chow.
Yes.
All right, thank you. Give me 30 seconds to end the meeting. Thank you, everyone who's attending and who's watching.